Good afternoon. Thank you for being invited for this conference. My talk will be current challenge for control, diagnosis, treatment, and risk stratification of Chagas disease in Brazil. I'm Roberto Ssaraiva. I'm from Oswaldo Cruz Foundation. I'm a cardiologist, and I do research on Chagas disease as well. So, as was said by previous people, Chagas disease was described by the Brazilian physician Carlos Chagas, caused by the trypanosoma cruzi. But it's been here probably like thousands of years ago, as DNA from T. cruzi was found in mummies from South America. This is one of the most prevalent infections in Latin America. And we still have around 6 million infected individuals, 30,000 annual deaths, 30,000 annual new cases, 14,000 annual deaths, 18,000 annual infected newborns, around 70 million still at risk to acquire the disease. Here you can see the protozoa and blood smear from a patient with acute Chagas disease. So after the infection, you have an acute Chagas disease phase, and most of the patients are not diagnosed, and they go to the chronic phase. If they're diagnosed, the treatment they may have a cure around 6 to 8%, but 1% of new cases receive timely proper diagnosis treatment. And death can occur. In Brazil, it's around 2% of patients with acute Chagas disease may die. They go to the chronic phase, or most patients go to the chronic phase. Most of them, you go to the indeterminate form, that they don't have cardiac or digestive involvement, but they do progress to cardiac disease, like 20 to 40%, but digestive form 10 to 15%. And some have cardiodigestive form 2 to 5%. The digestive form may have a megaesophagus or a megacolon. Okay? And amount of patients stay in a permanent indeterminate form. You don't know how many, which patients will go from here to here, or how many who will stay here. It's a big question. In the acute phase, you have a high parasitemia, so parasitological tests are used for diagnosis, and you go to the chronic phase. But the parasites are very few in the bloodstream. They go inside the cells. It's an intracellular parasite. So you need serology tests to do the diagnosis, or molecular tests to do, like PCR, to do the diagnosis. So acute Chagas disease, most vector-borne cases are asymptomatic or present self-limited symptoms, and you go to the chronic phase. There are lots of different things that the patient can complain, but most important is the prolonged fever, more than 7 days. Prolonged fever in an endemic area, the doctor must ask for Chagas disease tests. And the main complications are myopericarditis. Here you see a heart and a pericardial fusion around their heart. That's the patient can't die because of the pericardial fusion. And here you see the skin rashes of patients. Another complication is meningoencephalitis, more common case of Chagas disease reactivation. Here you see the diagnosis by seeing the parasite in cerebrospinal fluid and the cerebral edema in a CT scan. Cardiac form can be classified. We classify cardiac form from stages A to G. And stage A has abnormal EKG. I'm not going to say all the different things that can happen in EKG, that would be another class. But patients with abnormal EKG and a normal echo, we classify as stage A. When the parasite kills the myocardium, it's replaced by scar tissue, fibrosis, and then you say that they are in the stage B, if they don't have heart failure symptoms. When they develop heart failure symptoms, we tell that they are in stage C, and end-stage refractory heart failure, stage D. See here, patient is stage D. With a severe heart dilation, and see that heart almost do not contract, okay? Well, different from this patient here. So Chagas disease Brazil in the past was confined to rural areas. Now it's in urbanization, right? So it's in the cities. Main form of transmission was vector-borne, because the kissing bug is to hide inside the cracks of mud houses and feed patients during the night. Also, they could live close to the houses in places with domestic animals. Here is the triatom infest, that's the main homicidal vector. Here were another species while they're feeding, and at the end of the feeding, when they get full of blood, defecating, and these infected forms are here, and the patient then scratches the skin, get through the eye or get through the bind inside the inside. So there was in 75, there was a screening in the rural areas in Brazil, and 4.2% of the population was positive. Then control programs were initiated, 75, trying to eliminate the triatom infestans. So that was the distribution of the species in the Brazil. And after starting spraying insecticides in all rural houses in Brazil, it was decreasing until after 30 years of work, the triatom infest was eradicated from Brazil. Together with that, other species also decreased. But the triatom infest could be eliminated because it's living only inside the house, not in the forest. So after this control, and after also blood donation control, there was a drastic decrease in new cases in Brazil. There's another survey prevalence that was done between 2001 and 2008, only in children up to 5 years old. So 100,000 children were tested, and only 32 were positive, with a prevalence 0.03%. And most of them were due to congenital transmission. So you can see that vector transmission was a good job. And here's that I'm saying that the alternate blood in the count status of Chagas disease since early 19. So if a patient tells you that he got a blood transfusion after 1992, he considers that he's not at risk for Chagas disease. From 2007 to 2018, 29 million samples of blood donation were tested, and the positive were only 0.2% were positive for Chagas. So there was a decrease in mortality rate, and this is the mortality rate by the age of the patients. Out on the young, the decrease was higher. Nowadays, more than 75% of the patients who die are older than 60 years. This change in the mortality rate was due to the decrease in new cases, also to improving healthcare access and improving socioeconomic conditions. So there's an increase in life expectancy. Population is now older, but they still have like an annual 4,000 deaths to Chagas every year. But this number is underestimated, because many people who die of Chagas do not have Chagas in their death certificate. However, in the last 2 decades, there was an increase in acute Chagas disease. Here, the number of acute Chagas is increasing, and we saw that this increase in the north region, with 3,000 acute Chagas disease cases. So the acute Chagas disease became reportable again in 2000. The main mode of transmission of this acute Chagas disease was oral. So we have here vectorial in yellow and oral in red, increasing the transmission by this oral mode of transmission. just food contaminated by teratoma in feces or tracheotomy. And here the map where these cases occur, and most of the cases in the para state. In the last years, we still have like 300 cases per year in the para state. It dropped a bit during the COVID pandemic, probably due to subnotification, and 85% is due to oral transmission. And the main food associated with that is the açaí, is the palm tree, the açaí fruit. The açaí can be contaminated during the collection in the forest, during transportation, or during the preparation, if the bug being attracted by the light and fell in the place where the açaí is being under juice. However, açaí properly washed and pasteurized, there is no risk of Chagas disease transmission. Okay, most cases occur in rural areas with artisanal production. Another problem is that although the teratoma infection has been eradicated, other species can still transmit the disease. There are lots of species throughout the Americas, and in Brazil, from 2014 to 2018, these are the main species that are found inside the house or around the house. The Teratoma pseudomaculata, sordida, and brasiliensis. Mother to child is another transmission that still occurs in Brazil. We estimate there are around 500 annual cases of congenital infection in Brazil. And the average risk of transmission from the mother to child is 2%. It's higher in the South region, the Rio Grande do Sul state is higher, as it's also higher in Argentina, because it's probably because of different genetics. There is no current precise data on Chagas disease prevalence in Brazil. Only in 2020, just established the chronic Chagas disease will be reportable. So the most recent estimative point of prevalence between 1% to 2% of the entire population. So there's a estimated number of patients with Chagas disease in 2020, according to the form of the disease, can vary a lot. I said that around 4,000 people die every year, and most of people who die because of the cardiac form. That's a high morbidity and high mortality, due to sudden cardiac arrest, arrhythmias, heart failure, and stroke. Patients with Chagas disease heart failure, they die more than patients with heart failure due to other causes. Here's time, here's the guys that are still alive. And why is that? Because they have more arrhythmia, more bradyarrhythmias, more tachyarrhythmias, and they have a lower arterial pressure, a lower heart rate, makes it more difficult to treat them. And also have more cardiometabolic events, more stroke. So there are lots of different models trying to predict who has higher risks for dying. And the left ventricular ejection fraction that shows the contractility of the heart is the most strong constant mortality predictor. Dr. Haas published this score, taking into consideration the heart failure symptoms, the size of the heart, changes in the global or segmental wall motion, in the echo, arrhythmias in the Holter, a change in the EKG and male sex. So you get more points, you get from low to high risk. Another risk prediction model came from some trop study. They use age, functional New York Heart Association functional class, heart rate, cardiac duration, and BNP. And they also divide patients into low, intermediate, and high risk according to the points they have. Or we can use just the Chagas disease classification. This is our patients. If no cardiac form, stage A, B, C, and D, you see that as they go from the stage A to the stage D of the cardiac form, the survival gets really poor. Another thing in Chagas disease is stroke. Stroke is in endemic areas. Chagas disease is one of the main causes of stroke, and there are specific risk factors for stroke. here the aneurysm, the apical aneurysm, there is an area that does not contract, so it expands, so the blood stays there and make a clot, and then the clot can go from there to the brain, make a stroke. Here's another clot here. So patients with apical aneurysms, LV thrombus seen in the echo, severe dilation, LV start dysfunction, older atrial fibrillation, all these are patients with higher risk for stroke. And there's continuous research on new cardiovascular predictors using echocardiography, using cardiac MRI, for example. And here, for example, left atrial volume, patients are a higher size of the left atrium has more dimor. Measure myocardial contractility, which is lower myocardial contractility, dimor. Fibrosis, at the MRI can see the fibrosis, and patients with fibrosis also dimor, and they have more risk of arrhythmias. There are other risk factors being studied, biomarkers. There are lots of different biomarkers that have been studied. So far, brain-direct peptide, troponin T, but also positive parasitemia. For example, patients with positive parasitemia look that they have a worse prognosis. Here, positive blood culture, if a worse prognosis than a patient with a negative blood culture, probably because they have more parasite load, because parasites are replicating. And they have a recent research showing that BNP and positive PCR for the cruise are independent predictors of cardiovascular events. Also, we don't know how to identify which patients with the indeterminate form will progress to the cardiac form. There is no defined risk factor for Chagas disease progression. You do as an annual EKG, looking for progression. But when there is a change in the EKG, the patient has already progressed. So there's new image methods and genetic testing trying to identify those at increased risks. Here's subtle change of myocardial contractility, showing these patients have more progression than patients who did not have that. So we have lots of challenges still in Brazil. For transmission, we need to keep control surveillance of threatened species. We need to integrate vigilance work, taking together municipalities, state and federal levels, continue research. We need to improve house condition, and need to take community education so they know what to do when they see bugs. We need to train people to proper food handling preparation so they don't have acute Chagas disease, continue healthcare workers education to diagnose and treat all acute Chagas disease cases of primary care. In congenital transmission, although children with congenital transmission is an acute case, Chagas disease, so all these children must be followed and treated. Ideally, all the women with chronic Chagas disease in childbearing age must be treated as a decreased risk of congenital transmission. Although you know that there is no national compulsory surveillance for Chagas disease in pregnant women yet, but a recommendation for screening in endemic areas. And Cuida Chagas is, has been, people have talked about it already. It's from 1983, Cruz and Opposite. It's trying to establish a policy of universal screening for Chagas in pregnant women and identification, treatment, or infected newborns. So there is be a future with no newborns with Chagas disease. And we also need to identify all chronic patients. Most patients with chronic disease in Brazil, they don't know they have the disease. And most patients who know about the disease, they don't know that there's a treatment. So we need to identify and notify all chronic patients. For that, we need education of the patient and community, integrated work between health services, and we need to involve community. There's lots of social pressures going on. An example is Expresso Chagas. We have here the people of the community being invited to know about Chagas disease, look in the microscope and see the parasite, and being tested for Chagas disease. As previous speakers told, there are lots of barriers for etiological treatment. There are only 2 drugs available, but there are diverse side effects, up to 30% by non-treatment. If you do a close surveillance of the patient with treatment, seeing the patient frequently, you can identify the side effects, treat the side effects, and then this number, 30%, can go down to 10% of treatment burden. But you don't have medical education for that. Most doctors don't know how to treat patients with Chagas disease properly. And also there's a lack of clear criteria. The result is less than 1%, in fact, people are treated every year. In Brazil, from 2016 to 2020, 1.4 million benzoyl tablets were distributed. It looks like a big number, but it treats like 7,000 patients. You need to do better. You need to do better because you have millions of patients not treated yet. And so there's a need to develop new treatment strategies so that you can increase the number of patients treated and effectively treated. Also, there are challenges in Chagas disease complications treatment. Patients who go to the cardiac form, they have lots of different complications. They can die, they can have lose their quality of life, but you can do treatment for these patients. You can treat the heart failure, you can treat the arrhythmias, you can avoid complications. But there are few studies that include Chagas disease patients. So you apply the recommendation for pacemaker implantation or heart failure arrhythmias, develop other conditions. So there's no firm scientific evidence. That delays the implementation of beneficial therapies in Chagas disease guidelines. Also, there's a problem to access specific expensive treatments. There are few ongoing trials to look into the complication of Chagas disease, testing, for example, ICDs for prophylaxis of sudden death, testing new drugs for heart failure. So the early identification of patients at the early stage will be important so that you can treat these patients and avoid the complications so they can have a better life. So our dream is to have no new cases, no infected newborns, or chronic patients identified and treated for their conditions, the mortality drop and patient dignity and quality of life rescue. Thank you, people. And this is a photo of my team. Okay, thank you.